This is Med School Radio. We're looking at the most likely topics you'll see on the USMLE. Okay, we're looking at Med Bullets. Step 1, acute pancreatitis. A 35-year-old man complains of rapid onset of mid-epigastric pain with radiation to the back after eating a large meal. Physical exam shows low-grade fever, epigastric tenderness, and decreased bowel sounds. Abdominal radiograph shows localized dilation of the upper duodenum and a small collection of fluid in the left pleural cavity. Okay, I'm just reading the sections here of Med Bullets. First one is introduction. Damage to the pancreas causing release of pancreatic enzymes that auto-digest surrounding tissue. Enzymes normally stored/secreted as proenzymes, which are activated by enzymes in the bowel lumen. Can be activated pathologically in acute pancreatitis by the acronym pancreatitis. So we have posterior alcohol neoplasm, cholelithiasis, renal, ERCP, anorexia, trauma, infections, toxins, incineration, stings. Anyway, I'll read them one by one. The P is for posterior perforation of peptic ulcer. The A is alcohol, which is the most common cause in adults. Next, N for neoplasm. C, cholelithiasis, cholecystectomy, increased calcium, biliary tract obstruction. Next is R for renal disease. Then E for ERCP. A is for anorexia. T is for trauma, seatbelt injury, most common cause in children. I is for infections. Think of the mumps. T for toxins/drugs. Thiazides, AZT, protease inhibitors. Next, I is for incineration. S, stings. Think of a scorpion sting that could cause acute pancreatitis. And this is more common in males and in younger age groups. Next one, the presentation. Okay, the symptoms: severe epigastric pain, described as steady and boring, radiates to the back. And this is due to retroperitoneal location of the pancreas, and it is relieved by leaning forward. Okay, there's nausea, vomiting, weakness, low-grade fever, and shock. And shock is due to the loss of fluid in the peripancreatic third space, which is defined as non-functional extracellular fluid. Next, tetany, which is due to hypocalcemia secondary to free digested fats binding ionized calcium. For the physical exam, there would be abdominal tenderness with guarding or rebound tenderness, diminished bowel sounds from a localized ileus, hemorrhagic pancreatitis, indicated by, and they list 2, gray Turner sign, which is purple discoloration of the flank, or Cullen sign, which is periumbilical purple discoloration. But jaundice is rare. Next, the evaluation, looking at the labs, you would see elevated serum amylase, okay? And lipase, but first let's talk about the serum amylase. This is initially increased 2 to 6 hours after the onset of pain, which is also increased in mumps. So you'd also see increased serum amylase in mumps. Next, elevated serum lipase. And this has a higher sensitivity. So if you're seeing an elevated higher serum lipase, it's acute pancreatitis. For chronic pancreatitis, you could see elevation of both or neither. Hypocalcemia, see above it says. Hyperglycemia due to decreased insulin release. Hyperglycemia due to decreased insulin release. Next, imaging. Abdominal X-ray, there would be a sentinel loop, which is an isolated, dilated loop of bowel seen in inflammatory disorders. Next, well, it says that it's caused by inflammation irritating the adjacent bowel. Another thing would be the colon cutoff. For the chest x-ray, it may show left-sided exudative pleural effusion. For the CT and ultrasound, it says that CT is the gold standard. And peripancreatic fluid would be seen, and pancreatic calcifications. Next thing to look at is the Ranson criteria, which is used to determine the prognosis. This would examine age, WBC count, glucose, LDH, AST, hematocrit, BUN, and calcium. What is the treatment? The treatment acutely includes IV fluids, bowel rest, NPO, nasal gastric decompression, antibiotics, oxygen, and pain control, meperidine. For the prognosis, prevention, and complications, patients will often require ICU admission, and the condition may be fatal. Pulmonary complications, you could see pleural effusions, atelectasis, mediastinal abscess, or even ARDS, ARDS. So it says released phospholipase destroys pulmonary surfactant and increases intrapulmonary shunting. Next, pancreatic complications, pseudocysts, abscess, which often results from E. coli and Pseudomonas sepsis. And chronic pancreatitis could be a complication. Another thing you might see is DIC, and lastly, splenic vein thrombosis, and gastric varices in absence of esophageal varices is the last thing written describing the splenic vein thrombosis. So let's look at one question. A 29-year-old female is hospitalized one day after an endoscopic retrograde cholangiopancreatography, or ERCP, because of vomiting, weakness, and severe abdominal pain. Physical examination findings include abdominal tenderness and diminished bowel sounds. A CT scan demonstrates fluid around the pancreas. Serum levels of which of the following are likely to be low in this patient? I'm saying low, not high. So the answer here, well, let me give you the choices. Is it calcium, glucose, amylase, lipase, or triglycerides? The answer is calcium. The patient is hospitalized one day post-ERCP with symptoms and imaging suggestive of acute pancreatitis. In acute pancreatitis, serum amylase levels are elevated, and free digested fats may bind with serum calcium, causing hypocalcemia. One more time. Serum amylase levels are elevated, and free digested fats may bind with serum calcium, causing hypocalcemia. So lastly, let's more in this description of this question. It's good to read these. And MedBullets has some good questions that follow, even with the free account. Well, I think they're all free, but you have to sign in if you want to be able to see all the questions. Sorry, there is a paid account. I think you can see a lot more step one questions. Anyway, if you just sign up, you get to see more than if you just go in without signing in. Okay, so it says ERCP is the third most common cause of acute pancreatitis following alcohol ingestion and gallstones. Acute pancreatitis symptoms include nausea, vomiting, severe epigastric pain, weakness, low fever, shock, and tetany due to hypocalcemia. Physical exam findings include abdominal tenderness, diminished bowel sounds, and jaundice, which is rare. And the treatment includes pain control and acute management. This would be IV fluids, bowel rest, NG decompression, antibiotics, and oxygen. So there we have it. This is acute pancreatitis. Thanks for joining me on MedScore Radio. Go into MedBullets if you want to see more. Thank you.